Hi everyone, and welcome to the latest Molecules to Minds lecture from Aston Originals. The aim of our Institute of Health and Neurodevelopment is to unlock the potential of research to support health and development of children and young people. And our researchers are answering the questions that matter to children, young people, their families, and the services that support them. And I'm delighted to introduce one of our researchers whose work is doing just that. Dr. Rebecca Knibb is an Associate Professor of Health Psychology at Aston University, and she has 30 years of experience of conducting research into the psychological impact of allergies. Her research interests include the health-related quality of life and mental well-being of children, adolescents, and parents who are managing allergic conditions and asthma. And her research group is running projects to improve understanding of allergy management and improve global access to psychological support for food allergy. They're also currently developing interventions to help patients and families manage food allergy anxiety. Rebecca's the chair of the Psychology Working Group for the British Society for Allergy and Clinical Immunology, and she sits on the UK Expert Advisory Group for Allergy. She's also a member of the European Association for Allergy and Clinical Immunology task force groups, including a task to investigate the impact of allergy on adolescents. Rebecca is now going to share with us her exciting work on the global access to psychological services for food allergy. Please feel free to send in your questions using the comments function, and we'll have some time at the end of Rebecca's lecture for Rebecca to answer them. Thanks, Rebecca, very much for your time today. It's over to you.
Thanks very much, Jackie. Thank you for that introduction. And thank you, everybody, for joining us this afternoon. I'm absolutely delighted to be able to talk to you about our GAP study. The slides aren't up there yet, so there they go. Thank you very much. So what I'm going to cover this afternoon is just a brief background about food allergy, why we set up the GAP study, what our aims are, and some headline results from the first two phases. I'm also going to talk about what we're doing at the moment in phase 3 and what our next steps are. I know most of you in the audience probably know what food allergy is, or at least heard of food allergy. So I'm only going to go over this briefly. But food allergy is a condition that results in adverse symptoms after eating certain foods. And if it's allergy, our immune system is involved, and our immune system reacts to foods that most of us see as completely harmless food, and perhaps most of the time quite healthy food. But for those with food allergy, their immune system reacts to food that often most of us are eating in our general diet. So the foods involved can be very wide-ranging, but the main ones are things like peanuts, tree nuts like Brazil or walnut, milk and egg, wheat and soy, fish and shellfish. And it's a burden because we can't avoid eating. So we have to think about whether food is safe for us to eat if we have a food allergy. And so we have to continually risk assess and think about, is this food safe to eat, or is it going to make me ill? And so the management of food allergy requires a lot of vigilance to avoid the foods that could cause a reaction. So those with food allergy have to avoid the food itself, any food contained in other products, people or food utensils that have come into contact with food, and it involves lots of reading of food labels and constantly making those risk assessments. So people have restricted food choice. They may make sure they don't eat anything that includes a precautionary allergen labeling, so something like may contain peanuts. There may be some uncertainty knowing how to assess whether food is safe, and that can lead to some frustration, and particularly in our younger adults, maybe some risk-taking behaviours where they don't always necessarily adhere to complete avoidance of the allergen. Or it could lead to social isolation where people actually just don't go out or don't go to social gatherings where food's involved. The patients and their families tell us this is what causes the burden. First of all, that unpredictable nature of food allergy. You may be well the majority of the time, your child may be well the majority of the time. But a reaction to food can come out of nowhere. And the severity of the next allergic reaction is often not known. So you may have a number of quite mild reactions, but doesn't necessarily mean that the next time will also be mild. It could be much more severe. And because food's involved in so many things we do, that it has a big impact on our social lives, on eating out, on holidays. It has an impact on school and work. And it has also that economic impact. So foods that are free from cost a lot more. Sometimes parents have told us that they've not gone back to work so that they can look after their child with allergy. And there's lots of extra time needed to shop and read food labels. One of the things that causes a lot of anxiety is eating out, and some of the work we've done with the Food Standards Agency, looking at the impact on day-to-day life and quality of life of people with a range of different food hypersensitivities, including food allergy, has shown that particularly when people eat out, there is a big worry about whether they're going to have a reaction or a near miss. And this drives a lot of the fear around food allergy is that fear of a reaction. And there are things that might predict whether somebody assesses the risk properly, asks people about what's in the food. Maybe when they go to a restaurant, do they ask the chef, do they ask the waiting staff? And so some of our work is starting to look at what sorts of things drive that risk assessment behaviour and what sorts of things affect their quality of life. And we find often that young adults are less likely to tell food businesses that they have a food allergy or a tolerance than older adults or parents. So the work looking at the impact on food allergy on children and caregivers over the last 20-25 years or so has been brought together really nicely in a couple of systematic review papers by Jennifer Prodiger's group. Jennifer is in Canada and is one of our collaborators on the GAP study. And consistently, the research shows that food allergy has this big impact on quality of life on children and teenagers. And especially as children start to get older, the impact seems to become greater. They become more aware of their food allergy and it's affecting more of their social life. There's lots of distress as well, so anxiety and low mood and fear and worry. And there's lots of worries about the consequences, particularly outside of the home and those social consequences of food allergy. And similarly for caregivers, again, really consistent messages that parents are reporting a reduced quality of life. There's a bigger impact when the child has perhaps more than one food allergy, they're allergic to more than one foods, or they have other allergic conditions. So things like they may have asthma or eczema as well. And the things parents talk about is that unpredictable threat of exposure and that impact on their social life. Anxiety is also something that we're seeing more and more connected to food allergy. And this really nice review paper by Laura Poloni, is also working with us on the GAP study, has looked at the different ways in which people may react to their food allergy, with some people having really high anxiety, but not knowing how to manage their food allergy very well, or people with not much anxiety and also don't know how to manage their food allergy very well. And both of these things can lead to a big impact on life and can affect how people do their risk assessments and whether they eat things that are safe to eat. And so that level of anxiety, some of it may be beneficial because it may drive and encourage vigilance, but we know that too much is detrimental, and striking that right balance can be really difficult to achieve. So we have lots of research showing the impact. And what we're trying to do now is to think about, well, how can we support these patients? How can we support children and adolescents and caregivers, and also actually adults as well? Adults are very much a forgotten group of patients with food allergy, as a lot of the research focuses on children and teens. So we're starting to look at different interventions. These are two reviews that have been published by our group, looking at interventions for caregivers and for children, showing that CBT-based interventions, so that's cognitive behavioural therapy, does seem to be quite effective for parents and for children, particularly those who have got quite high levels of food allergy-related anxiety. and the online interventions as well. So not necessarily needing to be face-to-face in person within a clinic, but you can run online interventions and group interventions, particularly if they're facilitated by a healthcare professional. These are also appearing to show some promise. But the complicated factor and the issue is that although psychological support by psychologists is helpful, we don't have enough psychologists to go around. So we have this big unmet need for psychological support. Where we're seeing psychology services within pediatric allergy, there's great demand and the psychologists are reporting lots of success. But there's very little funding dedicated specifically for psychological support for food allergy, and access across the UK is quite variable. So this study here is one that we ran very recently, where a paper is under review at the moment. And we found that once we'd surveyed psychologists and healthcare professionals across the UK, on average, the psychologists had less than 6 hours a week to work with food allergy patients. And most of that was within sort of the south and the southeast, so London and the south of the UK. Once you got into the Midlands and the north of the UK, there were very few psychologists telling us that they had any dedicated time at all. One of the biggest barriers to this is funding. So when we asked, what's stopping you offering more services, it's funding, it's staff capacity, it's lack of clinical time. And these are the sorts of things that they're telling us they're having struggles with. The psychologists also told us that they strongly disagreed that there was sufficient capacity to take all of the referrals, and strongly agreed that there was lots of unaddressed mental health needs. And if they could receive more referrals, if they had more capacity, that would be much more beneficial. And we're also finding a similar pattern in the US. So this is not just a UK issue, but Linda Herbert, who's another of our collaborators on the GAP study, found similar findings in the US from their survey, looking at participants who were seeking psychological treatment for food allergy related concerns. About 20% reported out of their sample that they were, but only about a quarter of those actually were able to find any resources or support available. And lots of barriers to accessing that care were reported. So this is why we set up the GAP study. We wanted to look at, well, what is this access to psychological services? What is the uptake? We sort of know what's going on in the UK and the US, but what about elsewhere? So we wanted to explore this in more detail, and we wanted to do this in 3 phases. So the first was to run an online survey across as many countries as possible to look at the needs, access and uptake of psychological services, and then to follow those up with some more in-depth interviews and a follow-up survey, and then finally to develop and pilot some online resources. So what have we done in the first phase? This is our online survey. We developed the survey with patient organisations across a number of different countries, and we had the survey translated into different languages, put it online, and we recruited through a number of different ways of patient organisations, through the social media, and through some online survey panels as well. And we got a huge response rate. I mean, it took us a while to collect the data, but we got, our goal was to try and recruit over 100 adults and 100 caregivers for each of sort of the main countries that you can see listed there at the bottom. So in the end, we had well over 1,000 adults and nearly 2,000 caregivers took part. What do we find? What was the headline news? It was even more striking than we thought. 73% of the participants across the whole of the surveys were reporting food allergy related distress. So we can see here in this graph, it's split by adults, caregivers and children. And you can see 77% of caregivers are telling us that they have food allergy related distress. About half of the children, so caregivers were reporting for their children, and about half of them said their child had as well. When we asked them, well, have you been assessed? Have you been screened? Have you been asked about distress? Well, much less, about 1 in 5. less than 1 in 5 actually assessed for that distress. We looked at the different types of distress being reported. Hopefully you can see this graph. I've split this up into adults, caregivers and children. And what this is telling us is that most of the distress being reported is very much around anxiety and worry. So anxiety about an allergic reaction was the biggest type of distress reported for adults and caregivers. Anxiety about living with food allergy, worry about getting allergen-free foods, worry about not being able to take part in social activities or using an adrenaline autoinjector. These are all things that we have seen before, but we've only seen them in certain countries. So a lot of the research was focused on the UK, perhaps some in Australia and Canada, some in the US, but we're seeing this across 27 countries in total. These are the things they're telling us. And some of the things are quite surprising as well. So you can see there food allergy related bullying. We've seen reports of this from children, from caregivers, but in our survey for adults, about a third of them were reporting food allergy related bullying, even in adults. What we found really interesting, which we didn't really expect, was that there were significant differences in the food allergy related distress across the different countries. And this was the same for adults, caregivers and children. So this is the graph for adults, and you can see that places like Brazil, the UK, Canada, really lots of people telling us that they've got distress. So in Brazil, nearly 95% of adults in Brazil saying that they had food allergy related distress, compared to only about half of those in France, Portugal and Germany. When we asked about, well, have you been screened? Have you been assessed? You can see in the orange bars there, the numbers are much, much lower. In the UK, really striking there, 2.7% are being asked about food allergy related distress, and yet almost 90% are saying they actually have it. Whereas places like France, you've got nearly 30% being asked out of about 50% who are reporting distress. And we see similar for caregivers. Again, here, really striking numbers. Brazil, Australia, the UK, Canada, USA, reporting really high levels of distress compared to Spain, France, Germany. And again, when we look at whether they've been screened or assessed for distress, much, much smaller numbers for places like Brazil and Australia and the UK, where the need is the most. However, places like Germany, about half of them are being screened or assessed. So really interesting patterns of results coming out here. We also found that when we asked people, have you actually seen a mental health professional? Out of those reporting, this is the numbers telling us that they'd actually seen somebody. So about a third of those from Brazil had seen somebody. Not that many in Australia. If we look at caregivers, only 13%. But you can see again that there is variability there. Portugal, only 4% of caregivers reporting that they've actually seen somebody. The pattern's very similar for children. About a quarter of caregivers reported that their child had seen somebody. And we asked, well, where did you get your referral from? So if you had distress and you went and you saw somebody, who referred you? And again, this was really interesting because less than half were telling us that they were referred by a healthcare professional. So most of the referrals, when you sort of add them all together, they're coming from friends, support groups, online, through social media. Whereas if you look at how many were actually coming from a primary care physician or an allergist or another healthcare professional, less than half of them were coming from those sources. The support that they received was variable. A lot of people telling us that they had received some cognitive behavioral therapy, some of them receiving support with just general daily struggles with their food allergy. Very few are receiving procedural support. So this is around support around things like anxiety about giving an adrenaline autoinjector or going for a food challenge or a skin prick test. We also asked whether they were knowledgeable or helpful. And again, they were telling us that actually they were quite helpful, but not quite maybe as knowledgeable about food allergy as would have been beneficial for them. And then finally, we asked them about, well, what are the barriers? What were the barriers to seeking help from a mental health professional? And the biggest one here you can see is cost. So this is across all of the adults and parents in the survey, but we broke this down by country as well. And for almost every single country, adults and caregivers are ranking cost as the biggest barrier. Even in countries where, like the UK, where healthcare is free at point of service from the NHS. And I think what it's telling us is perhaps that because the psychologists aren't there, because there isn't a service to refer to, they're looking towards private care, and that is that costs a lot of money. So for pretty much every country, they were telling us that cost was the biggest barrier. So our conclusions from phase 1. So across the UK, parts of mainland Europe, but not all of them, North and South America and Australia, we have large proportions of adults, parents reporting food allergy related distress, and few of those have access that care. The majority of those that do access it find it helpful, but most of these are not being referred through the allergy services. And the barriers, which mostly are cost, indicates that perhaps something easily accessible or free resources or free support is needed to help these families. So ways in which we can try and improve access is particularly needed. So we're still working through some of the data for phase 1. The main paper has now been accepted in Allergy Journal, and we're now looking at the different types of distress. And we're finding actually that when we're looking across all the different types of distress and how much distress is being reported, again, we're finding differences across all of the countries. So in our phase 2, we really wanted to follow this up in a bit more detail. So one of the ways in which we're doing that is by running more in-depth interviews across different countries. So we're offering the interviews in 6 languages. Like the phase 1 survey, the languages are the same, and like the phase 1 survey, we also have Canadian French and we have Brazilian Portuguese. And we are interviewing, or we have interviewed, adults and caregivers recruited through the patient organisations. And we've recruited and interviewed approximately 15 to 20 adults and 15 to 20 caregivers from these countries. So from France, Italy, and the UK and Europe, from Canada and the USA. Brazil is the one where we're still doing the interviews. We've finished all the others, and Australia. So we have done over 200 interviews. So this is a massive, massive data set, qualitative data set. And it's providing some real insights into what's going on in these different countries. We held all the interviews in the language of choice for the participants. So we had researchers who were bilingual, and they transcribed verbatim in the language that the interview was carried out, and then have translated the ones that were needed to into English. And then we're using a template to analyze the data to start off with. We're finding that this is the easiest type of analysis to do. So we've developed this template based on analysis of some of the interviews, and then we're using that template to apply that to the rest of the interviews. And the interviews asked about impact on lives, but mostly they focused on the experiences with healthcare and psychological support, and what support people would actually like to have and in what type of format. If you're interested in the methodology of this and how we've managed to do so many interviews across so many countries in so many different languages, we've just published a paper on this, which has just come out in Clinical Experimental Allergy, and that reference is at the bottom there for you. So I just want to take you through just some of the key findings from the interviews. There is so much data. This is just a real sort of little snapshot, and we're writing this up at the moment. But what we've analysed so far is the main findings from the UK. So if we look at adults to start off with, they're finding that their experiences with healthcare services very much mirror what we saw in the results from the survey, where they're saying there's lots of them reporting distress and very few of them being able to see somebody to help. So a quote here says, I've certainly never had someone take it as seriously as I would have liked. And in terms of emotional support, there wasn't anything at all. I felt stupid, like I was wasting their time. Yeah, and it was absolutely no help at all. And one quote that was really striking, which was, "You've got anaphylaxis. Here's some EpiPens. Bye." That was it. No support over it. So EpiPens are one of the different makes of adrenaline autoinjector that we have in the UK. And what we're finding is that, particularly within primary care, the experiences are that they're not really asked about distress. That seems to be being dismissed, and they're not really being provided even with perhaps information about how to manage their food allergy. There's also issues around sort of societal knowledge and awareness of the general public and hospitality. So one quote here saying, "Can't guarantee that you don't have cross-contamination. You're just there thinking, well, they're not even going to try." So it just shows you that impact of eating out that adults are experiencing. Don't think they realize it's deadly. And this is what we're hearing quite often from adults, from children, from adolescents, from caregivers, that people don't perhaps realize the nature of allergy, and that it's not just somebody being picky, or not just somebody saying, I need to avoid that food because it'll make me ill, but I need to avoid that food because it's potentially a life-threatening situation if I eat it by mistake. And we're seeing it in this country, as well as we're seeing this in the US as well. There's more awareness by food businesses, but then they're much more wary about things like being sued. And we're finding that some of our caregivers and our children are saying that they're having to sign disclaimers or waivers if they eat at certain establishments. There seems to be a big unmet need and a need for more holistic healthcare. So we asked our adults, what would you like? Any online support? If that sort of thing existed, that'd be great. Suppose for me, that would actually be better because my time is limited. So that's one of the things we're thinking about. How can we support these people? Online support seems to be something that they're talking about, but also this idea that it would be great actually if psychological help was there all the time. So really, could we be offered it automatically? And peer support we know is really helpful. And so some of our adults were telling us about being able to talk to somebody about coping and how to cope with it would be great. We've also analysed our UK parents, and these quotes are all about the healthcare experiences that our parents have had in the UK. And one of the striking things was them talking about their experiences with primary care and their GP, and almost trying to get past a gatekeeper to have for their child to be seen at an allergy clinic and have their potential food allergy properly tested and get some proper advice. So caregivers felt that their concerns and worries regarding their child were not perhaps always taken seriously by GPs. Obviously, there is variability in the UK, and we're only, we only spoke to 15 parents, but this is some of the things that they were saying. You go to the GP who hasn't got a clue, or others saying, well, actually, GPs are going to have a good understanding, but it's not their specialism. The parents also started talking about this need for a holistic approach to healthcare. So caregivers were often unable to access psychological support and felt that it should be integrated when they see other healthcare professionals at clinics. So from a lens of allergy, I'd say our patient care from the mental health perspective is really bad, so non-existent in fact. We had some variability in the benefits of psychological support. And then I think partly this is from some of our participants not really knowing what a psychologist could offer. And one of our parents within the UK was saying, I don't know what difference it would make. There's nothing they can do. However, somebody who saw a psychologist said, actually, they were brilliant. I saw a psychologist for a while, about 6 months, and then that sorted me out. So those who've been able to actually access the support have found it really beneficial. And our parents talked about trying to access help outside of healthcare as well, and they discussed means of support they'd find helpful. So this included things like online support and resources that they could share with peers, share their experiences with peers and get help with learning more about their child's food allergy and how to manage it. So they talked about the benefits of perhaps finding a network of people where you could share experiences and not feel so alone, and sharing with people in the same sphere as you and finding that commonality. We've started looking at those healthcare experiences across the different countries, and this is very much in its infancy. We've only just started looking at this, and we have started a comparison between the UK, USA, and Australia, and we'll be adding in Canada and some of the other European countries as well. But we're finding that their experiences are quite different, and they're different in terms of access. They're different in terms of their expectations of what the different healthcare professionals can provide, and then they have different experiences as well. So there's an adult here from Australia saying, I don't really have that expectation of them talking about primary care like a GP, although it's nice when they express concern. And this seems to be very different to what our patients within the UK are telling us, where they were saying, actually, my GP doesn't really know, and I think they should ask, and I think they should refer me. So there were very different experiences and expectations of what support they should be getting from primary care. A US in the adult, the other way around, an adult in the US talked about insurance, and of course their healthcare system is very different to here. So they were talking about when they were younger and that their parents were like, I don't think we'll be able to afford it. Our insurance is really limited, when they were talking about having different tests for allergy. And then in terms of psychological support, again, an adult in the US here was talking about CBT definitely helped me to cope, just be more accepting and more kind and more loving towards myself. So those patients we found who had been able to access that psychological support, again, we're finding it really useful. And I think that this is something we're going to be looking at in more detail over the next few months to try and get much more of an insight into the different experiences that people are having across different countries and whether that supports what we found in our phase 1 survey. One of the other things we're doing to also try and explore things in a bit more detail is a follow-up survey. So this is what we're currently planning on. And this is our follow-up survey that we're just about to launch. Again, just like the survey in phase 1, it's in all the different languages. We're going out to as many countries as we possibly can. And this time we're asking about information that we thought was perhaps missing from our phase 1, or where we wanted to explore things in more detail. So although in phase 1 we asked about all the different types of distress, we didn't really get an idea about the degree of that distress. So was it just mild, or every now and again, or infrequent, or was it distress that was very experienced all of the time? So we're going to get our participants to rate the levels of distress. We want to see how severe they may be feeling that distress, and whether, again, that is that different across the different countries. We're going to ask them about their quality of life in a little bit more detail. And we know lots of research over the last 20 odd years looking at quality of life, but again, it's often very limited to only certain countries. And because we had such great success in our phase 1 survey, we want to try and get some data on quality of life from these countries where nothing's really known. I mean, Brazil was a real eye-opener. We didn't even expect such a big response from Brazil, and we had well over 200 parents filling in our survey just from Brazil. So we want to find out a little bit more about impact on life in those countries in particular. But what we're going to look at in a lot more detail is what their experiences with food allergy services are, and particularly regarding that referral through to psychological support, and then what their experiences are when they get that psychological support, and a few more questions around what sort of support would they like. So that survey is coming. So from phase 2, really, we've found that individuals with food allergy are facing these numerous challenges, and that psychological therapy, they're telling us, helps if they can get it, if they can get that support. But there's a big unmet need across the globe. There is an unmet need for that psychological support. And so some low-cost resources or free-to-use resources might help this patient group. And maybe also particularly from the interviews, that further education of healthcare professionals, perhaps particularly in primary care, may be important to ensure that this impact of food allergy on psychological health is not dismissed. So this brings me finally to what we're doing now. So this is phase 3, where we're developing and piloting some online resources. And they're not just resources, really, because there's some absolutely fantastic resources out there that are provided by the different patient organisations. And they're really helpful, and we're going to be signposting people to those patient organisations where we can. But we know from talking to people and from the systematic reviews we've done, from the interviews we've done, that if we can put on a toolkit that is based more on psychological theory and psychological support, including things like cognitive behavioral therapy, we may be able to help patients and families, particularly in those things that they're telling us about are causing the distress. So particularly around distress of having a reaction and not knowing how to manage it. So this is our phase 3. So we're calling this more of a toolkit. So we want to develop an online toolkit. And so what we're doing is we're going back to the interviews, and we're doing now a content analysis. So we're looking through the interviews, and we're looking to see, one, what are the key things that our patients and our caregivers are telling us that they need help with? And two, we're looking through the interviews to try and tease out ways in which we can provide that support. So the content analysis of the interviews so far that we've looked at so far are showing that the main things that people want help with is anxiety management, which is not surprising. Anxiety, one of the most common things that they were telling us they were suffering from in terms of distress. So they want help with anxiety management. They want help with managing low mood and help with stress. They also want some help with adjustment to diagnosis, supporting children in growing up with their food allergy, and supporting children with anxiety management. So this process of content analysis is ongoing. We're looking currently at the UK interviews, but we're also going to be looking at the interviews from Canada, from the US, and from Australia to start off with. And we're going to combine all of that and try and come up with a toolkit that maybe covers 6 or 7 key areas that are going to be helpful for our patients and our caregivers across those countries. We're going to be using health psychology theory, so I won't go into too much detail, but just the theory that we're going to be basing this on is the COMBI model, which looks at capability, motivation, and opportunity as a way of changing behaviour, and we'll be mapping that onto the behaviour change wheel, which looks at capability, motivation, and opportunity, but then maps that onto the different types of behavior change techniques that can be used. And we're going to be combining that with psychological aspects of psychological therapies, which we know are helpful. So things like cognitive behavioral therapy, motivational interviewing, acceptance and commitment therapy, compassion, self-compassion therapy, all of these sorts of things that we know are going to be helpful for people managing food allergy in themselves or in their children. And we'll also use the APPEASE criteria as well. So we want to make sure that whatever we do is acceptable, practical, effective, affordable, and that there is equity in terms of access and being able to use it. So this is what we're doing between now and the end of the year. We're going to be developing this intervention, and we're going to then sort of pilot it in the UK, in the US, Canada, and Australia. And then hopefully next year, we'll start to think about how we can get this out to people, and that our patients and our parents can have access to this and look to see whether it's helping improve their anxiety around managing food allergy. So these are our next steps then. We need to complete analysis of our surveys and our interviews, looking at experiences and types of distress across the countries. We're developing our online toolkit so that we can offer this psychological support, and we're going to test out those materials in. We only have funding for English at the moment, so we're going to be looking to test it in countries where English is the predominant language, and then we hopefully be able to get funding to be able to translate into different languages as well, and explore ways in which we can make sure that that toolkit is accessible to as many people who need it. So it just brings me then to thank everybody who's involved in this study. Our funders, as you can see there, IACI, Novartis, AMUN, and the National Peanut Board for funding the research. All of the patient organisations who are really helpful in helping us to recruit participants, and our parents and children for taking part, and our adults. And as you can see there, we've got a huge team of us working on this project, and lots of research assistants as well. And thank you to all of those. And thank you very much for listening.
Thank you so much, Rebecca. That was absolutely fascinating, and some real eye-opening statistics you've shared with us there. There were some things that really made me think about what it must be like to be living with food allergy, both as a child and as a caregiver. So thank you so much. We've got some questions coming in, so hopefully we can address some of those. So one of the first questions is, why do you think there are such big differences across countries? And indeed, as you were talking, when you showed the difference between France and Brazil, I was just staggered by the enormity of that difference. But people experiencing essentially the same problem, but such great differences in distress. And I wondered whether, is some of that about how acceptable it is to express your distress, or is it more about the food context? So is it just fundamentally harder to cope, for example, with your food allergy in Brazil?
I think it's a really complex question and a complex answer. I don't think there is one thing that is creating these big countrywide differences. I think we know that in different countries, people are allergic predominantly to different types of food. So it isn't like everybody's allergic to peanut, and that across every country. So some Mediterranean countries, they'll be more allergic to sort of fish and shellfish. So there may be differences in the difficulty in avoiding the food. If it's a staple food in your diet and it's something that everybody eats, there may be difficulties there in avoiding particular types of food. I think the healthcare system has something to do with it. So, for example, in Germany, you don't have to go to sort of a primary care physician to be referred. You can refer yourself directly to an allergy clinic. And we can see Germany is one of those places where distress is much lower. So I think healthcare system, definitely. Attitude also, I think, comes to play. A lot of our participants in the US were saying that they have a real sense of community and community support. And because they're paying for their healthcare and they have insurance, although cost was still a barrier, they may find it easier to access support through their insurance. And another thing we've been talking about within the team is distance. So the UK is really small, but our allergy services are concentrated in certain places. So, if you're living on one of the islands in Scotland, for example, you've got a long way to travel to get to an allergy service. But then you think about the distances in Australia or Canada. You're going to have to get on a plane and fly somewhere miles and miles to see somebody. And that's the sort of thing you don't really think about in terms of healthcare, just how people access it. So I think there's lots and different reasons, which is why we're doing a follow-up survey. We want to try and perhaps pick up a bit more detail about what is it about accessing the healthcare services, and what is it about this distress, and why are we seeing these big differences across the country. Some of the interviews have given us a bit of insight, but I think there's going to be lots of reasons. But we were really surprised at the differences.
Going to give you some great insight, isn't it, as you collect more of those interview data. That's great. Thank you. Okay, our next question is from Laura. So Laura asks, I know there are free smartphone apps approved by NHS for mental health support. Are any of these helpful for food allergy support as a low-cost option?
That's a really good question. I think what we're finding is that for food allergy, it's the food allergy anxiety in particular. So it's not just general anxiety, it's specific to food allergy. And so the support that's being offered by psychologists, particularly things like CBT and acceptance and commitment therapy, we're having to tailor very much that support for a food allergy context, because your usual CBT things about challenging thoughts and exposure doesn't work for allergy. So I think that some of the smartphone apps would be helpful for sort of general anxiety, but because they won't be specifically targeted for food allergy, that's the bit that it seems to be missing. And when we talk to people about people who've seen a therapist or a psychologist, if that therapist doesn't know anything about food allergy, their therapy has often not been very successful. So the knowledge about food allergy is really important.
It's got to be core to that support that people are accessing. Thanks, that's great. Okay, our next question is definitely coming. How can we get more psychologists working within allergy? You've spoken about the lack of psychologists in this area. How do we get more?
The easiest way is to pay them. And that's not going to happen. So the easiest way would be to have some dedicated funding. So where we have dedicated funding for psychologists for things like diabetes and cancer, those sorts of things, if we could have similar for allergy, that would certainly help. But that's not going to be something that's going to happen very quickly. So we're doing lots of things to try and improve the situation. So where allergy clinics have been able to put forward a business case for a psychologist and they've been successful, we're using those models to try and provide that information to other allergy clinics to say, here's a template sort of business case, here's the sort of things that you can put in there to try and get some funding for a psychologist. I think that we're doing quite a lot to try and raise awareness. So psychologists who are working within long-term conditions, for example, so health psychologists, clinical psychologists, hear about allergy and hear about what a fascinating area it is to work in, and we can try and encourage them to work with allergy clinics. So one of the things we're doing as part of our is now a permanent special interest group of the British Allergy Society, is our psychology group, and one of the things that we're doing there is trying to constantly sort of raise awareness. We also have a new developing national allergy strategy. So what we're hoping to do is to raise some awareness within the national allergy strategy, that psychology is really important and having psychologists is important. But I think it's a long-term thing. We're just going to keep plugging away and trying our hardest to get the funding in place in as many hospitals as possible.
Thanks. Yes, it's a marathon, not a sprint, as they say.
Yeah.
Next question. So are you doing a toolkit for children? So will the toolkit that you're developing be just for caregivers, or would it be appropriate for use for children as well?
We're starting with adults and caregivers, and if we can get more funding, we'll also do children. I think caregivers are it's a little bit easier to develop a toolkit for caregivers, and what we hope is that if the caregivers have that support, then that they'll be able to use that to help their children. So if we put in things within the toolkit around how a caregiver, a parent, can help their child develop and grow and manage their own allergies, then that's something that caregiver can pass on to the child. So I think we have the funding for that. If we can get further funding next year, we'll definitely expand out and try and do one for children as well.
Okay, that's brilliant. So thank you so much, Rebecca, for that fascinating talk. The lecture will be available on YouTube, and I'm sure Rebecca will be keeping an eye on the comments on the lecture, so that if you've got questions that you haven't been able to ask today, then feel free to get in touch either through YouTube or through Aston Institute of Health and Neurodevelopment, and we'll pass on that information to Rebecca. So once again, I'd just like to take the opportunity to thank you, Rebecca, for this fabulous talk, and wish you the very best in the next steps of your research project. And let's hope we can see some better psychological support for people with food allergy as a result of your brilliant work.
Thanks, Jackie.